I just really want to thank Jessamy and Dr. Hopkins for bringing us all here and having this conference. Dennis and I gave a talk out in Southwest about 10 years ago, and we had 5 people show up. So this is awesome to see all these people. And I think that now that there is a little bit more that we have to present, we have more options. I think that these are going to be very valuable. I teach at the University of Pittsburgh. We make sure that every medical student that comes through has at least some information about Down syndrome. Yes. And I hope after my 59-slide journey, I'm going to take you on for the next 59 minutes, that this will be as much of a, you will have as much of a curriculum as is in most medical schools, most internal medicine residencies. My hope is even when we just talk to those 5 people, I'll bring up a lot of stories, a lot of ideas of ways that symptoms can lead to a diagnosis. And I'm hoping that someone is going to find something kind of ring true with them, that they can say, hey, maybe I should talk to my doctor about some specific topic, that if any of these do ring true. So, and I'll talk a little bit about some of the things you've already asked about. I'll talk about, so COVID, I think, has had a huge impact in terms of changes in social dynamics, and we've seen a lot more regressive-like episodes from that. And I think we had a little question about obstructive sleep apnea. I want you all to shout out when I do a case that might be obstructive sleep apnea. We'll talk about that. And then mimics of Alzheimer's, and we'll go over lots of them. I have a new one that I'm going to add to my slide after talking to one of the parents here. So I mentioned the Down Syndrome Medical Interest Group, USA, and on their website there is a big purple button that says ECHO. And if you click on that, it'll give you information about ECHO. ECHO is that national program where a primary care physician or a psychologist or psychiatrist or neurologist, anyone that doesn't have as much experience with Down syndrome but would like to present a case in front of 16 experts, this is something we do every month. If it is something that is more popular, we might do it more frequently. So please do check on these. And the other thing that it does is it might get your primary care physician, your psychologist to meet some experts, and hopefully get them excited to do a little bit more of the search into the literature. So my job, what I'm hoping is going to happen for me, I would like to eliminate my own job because I want that everyone knows about all these medical issues with Down syndrome, so I'm no longer needed. That's my goal. I hope it happens when I want to retire anyway, but I guess we'll see. So our clinic in Pittsburgh, I put this up here because I couldn't do this without the clinic that we have. It really does take a village. And on the blue side is the pediatric world. Dr. Bulova runs that center. We have 3 practitioners. We have a nurse who just has experience with Down syndrome. Erin Kelly has a child with Down syndrome, and she's the coordinator. Elizabeth Sattler is our advocate. And boy, she is such a role model for our patients. It's really amazing to have somebody with Down syndrome and showing families and showing the people with Down syndrome, this is something you can do. I run the adult side. We have a coordinator there. We also have a psychologist who had 0 training in working with people with Down syndrome. It just took her having an interest, and after 4 years, she's now a national expert because there isn't any extra training. Yeah, so she's become a national expert just by working with people with Down syndrome over the 4 years. Dr. Philippink is our researcher. She's our developmental neurologist. And I don't have on this slide because she's brand new. We now have a nutritionist who, again, no extra training in working with people with Down syndrome, but she's now a national expert, just having enough experience and knowing what works. And I'll talk a little bit about some of the things that I think do work. In terms of adult Down syndrome centers, how many are there? There are about 25. There was a study by a different Dr. Santoro, who is not related to our Dr. Santoro here, Stephanie, that looked at the population in terms of adults with Down syndrome, about 125,000. The number of patients seen at these 25 clinics is about 6,000, which means that 95% of adults with Down syndrome are not going to a specialty center. And that's why we need to educate primary care physicians, we need to educate families to know the kinds of issues that do come up. Boy, it's really fun, I have to say, seeing the interest that has come in in looking into these issues. I think of Dr. Santoro as kind of like the Taylor Swift of the Down syndrome world, because everybody wants, maybe more the Travis Kelce, he can choose whatever one he wants. But it's funny, he's like a celebrity. It's very cool. It's very cool to see him there too. Okay. So I'm going to talk about the common conditions in Down syndrome, talk about ways to promote wellness. I'm going to spend a little bit more time on dementia because this is a topic that seems to come up a lot. And then review clinical aspects of the adult guidelines, things for you to look at of what tests you need to order, what are the things to be looking for. And I'm real curious, just for my poll for the audience, how many people have someone that they care about who is under the age of 10 who's here? Anyone? Couple. How about 10 to 20? Lots, 10 to 20, great, okay. So getting towards that transition time. So that morning talk must have been awesome. 20 to 30? Great, 30 to 40? Great, and 40 to 50? 50 to 60? Awesome. Anyone over 70? Okay. Fantastic. So I will try to cover every age group in my 59 minutes. We'll see how that goes. I just put up a quick case. This was a woman that I saw pretty early on when I started the center. Her father was a pathologist who taught in the medical school. She's 30, and she didn't want to leave the house. She'd had loose stools for years, was chronically underweight. And when they asked their doctor about this, he said, "Oh, that's just the Down syndrome." Okay. So my question for you, number one, yes. There's no need to look into more of this. It's just the Down syndrome. Or two, no, there are some medical issues that might cause these kinds of things. What do you think? 1, 2? Awesome. Awesome. Thank you. I hope that was a give me question. So does anyone know the kinds, what she might have? Something that causes chronic diarrhea, underweight? Fantastic. Right. So here's a perfect example of just knowing a little bit about what conditions are more common in people with Down syndrome. So about 6% of people with Down syndrome will have celiac. Our patients don't often say, "My stomach hurts after I eat gluten." They have a change in behavior. I wanted to put up a couple things are common behaviors and lab findings. These are ones you do not panic about. And I don't need to speak at all about self-talk because Dr. McGuire has already done that so eloquently. I'm happy to not have to go more into that. We have many patients with a very high pain threshold. I had a patient that came in who had an ankle fracture, and he was just walking around on it. He had a change in behavior a little bit because he didn't want to play soccer, which is understandable, but didn't tell anybody, "Oh yeah, my ankle hurts," and was still able to walk on it. It really took seeing that change in behavior. Complete blood count findings I put up here, and I'll talk more about hematology later. There are a couple very, very common abnormalities when you look at a general CBC that you should not worry about. They're worth following, but don't panic when you see abnormal. There's lots of bright red marks on when you get your labs back, and I don't think very, very common to see that. And then the other one is low pulse and low blood pressure. Just about all of my patients have a low pulse and a low blood pressure. I'm not saying it's not a problem. I have people that have fainting because their pressures are so low. There are conditions that can make this a problem, but on a daily basis, those are things that I see. The things that I really want you to look for is if you see someone having a loss of skills, if there's a loss of their groove, and again, I'm not talking more about the groove because Dr. McGuire already covered it, a loss of focus, a loss of empathy. Our patients tend to have pretty amazing empathy. And seeing that going away tends to be something worrisome. And then the last one is unintentional weight losses in our first patient. These are not ones to ignore. So as I said, you really have to look at behavior as a clue to diagnosis. One of the problems we have with Alzheimer's is it presents as a decline in skills, which is pretty nebulous. There are so many things that can cause a decline in skill. So looking at a specific behavior and trying to come up with a way to come up with what are the possible medical things that can cause that specific behavior. What psychiatric issues, those kinds of things. I I really encourage patients to be an active participant. And the first thing I always tell the students that I'm training is you talk to your patient first, and then you can talk to the family. But your patient is the reason that you're there. If you want them to be engaged, that's who you have to talk to first. And many of our patients really blossom when they are the center of the visit themselves. I really try to focus on that. This is probably my biggest point, my key point is patients with Down syndrome get many of the same medical issues as others, but they can present differently. And there are some issues that are much more common in people with Down syndrome. So if we didn't know about celiac disease being more common, not one that we would look for. And then in the visit, I'll talk a lot about prevention too. Is exercise important? What are the blood tests that you need? And we'll cover that when we do the guidelines. So many talks start out with a slide like this, which are what are all the problems? I don't like to start there. I like to start with the health benefits of Down syndrome. And the ones that are most common, and we've seen looking through some of the literature when we're putting our guidelines together. So we see this decreased risk of coronary artery disease. Don't see nearly the number of heart attacks that I would have expected, even age-matched. Hypertension, as I said, I don't have any patients on antihypertensive medications. Whereas my patients that don't have Down syndrome, probably about a third of them are on antihypertensive medications. And then the other thing I do as an internist is I'm always screening for solid tumors, whereas people with Down syndrome have a much lower risk of breast cancer, of colon cancer, prostate cancer, cervical cancer. We don't know why as of yet. I'm hoping we will find that out soon. The one that is more common is testicular cancer, so I will ask more questions about that, though still not common. It's still pretty rare. And then visual memory, which is just spectacular in so many of our patients. I think Dr. McGuire covered that pretty beautifully. This leads into another one of the very common common problems I see in Down syndrome that presents in such a myriad of ways. And I want you to think about this condition because it's so common, you may not see it present as it would in somebody without Down syndrome. So this is a patient who came in, he was about 40 with intractable seizures. 35. He had new onset seizures. This had been going on for probably 9 months when I saw him, and he would arch his back and he would shake, last about 30 seconds, and then he would come back. So they put him on anti-seizure medication. They tried to get an EEG, weren't able to get that. The anti-seizure medicine didn't help, so they added another. That didn't help, so they added a third, until finally, when I saw him, he was on 4 anti-seizure medications. Didn't seem to have any effect on the behavior, the issue that was happening, and he was very lethargic, as you might expect, being on 4 anti-seizure medications. So I asked them more about when these occurred, and they said, they always occur usually about 1 o'clock in the afternoon. And I don't know if you know much about seizures, but they really don't have that kind of a time frame. Doesn't happen at a specific time. But for him, this was always happening after lunch. They only lasted about 30 seconds. He did not have a post-ictal state and really came back to being himself pretty quickly. But as Dr. McGuire mentioned, really wasn't able to verbalize exactly how he was feeling. So what we found out was it's always happening after lunch. Why don't we see if it has anything to do with reflux? So we started with adding omeprazole, which is Prilosec, and all of his seizures went away. And we took him off all of his anti-seizure medications. The staff came the next time and said that he was too full of energy. He was a lot to handle after all of this. And that was the only complaint that they had. It really took knowing that something like reflux is very common, but is not always going to present with a patient saying to you, oh boy, I have this burning acidic sensation in my throat. And it occurs after I eat. I had another patient that came in with a new onset psychosis because she was ripping her shirt off. And they said she kept doing it in public, but it was after lunch. And it was because she was always ripping it off from her collar because her reflux felt bad. So she had a pretty big hiatal hernia. So again, we did the same thing. We put her on omeprazole. So this is a condition that is quite common and is not going to present in the most typical ways. So one to think about. The kind of GI issues you all already know about: celiac, fantastic. Difficulty swallowing, very common. Coughing and choking, I do a lot of esophagograms looking for achalasia, strictures, or just troubles with the ability to swallow. Very low threshold for doing some sort of a study for that. So I talked a little bit about blood counts in terms of hematology. So leukemia, as Dr. Santoro mentioned, is something that is on our minds. Dr. Velody, who runs the Children's Center, sees a lot of this before age 5, but it gets less and less common because there probably is a genetic component to it. So by the time someone comes to me in their 20s, very unlikely that they're going to develop leukemia at that point if they haven't already. It's much less common. The things that are so common is a mildly low white cell count. And I have so many patients that see a hematologist just to have that checked about every 6 months. Again, if it is dropping precipitously, if it drops it down incredibly low, then yeah, that's really important. But if it's in the 2s or 3s, I expect that to be that way for their patient's entire life. Many of our patients have large red blood cells. One study from JAMA mentioned that 2/3 of the patients just have large red blood cells. And then a mildly high red cell count is also really common. So those aren't things to be as worried about. We'll talk about when I would worry is if I have someone who has a relatively low count and then I watch it rise over over some period of time. This is something that's usually present throughout, so not something that changes. In terms of the lungs, 2 things about the lungs to know about. One is the pneumonia, influenza, aspiration. Those are really common. Pneumonia is the second leading cause of admission. So the leading cause of admission to the hospital is some sort of pneumonia, often from aspiration, swallowing troubles. We see that all the time. Second leading cause of death, pneumonia, influenza. We don't have great data on the pneumonia vaccine. I am a huge proponent of it, but I can't tell you I have a randomized controlled trial for the pneumonia vaccine. But I'm a big fan of having all of our patients get it, anyone over the age of 21. So I want you to tell me if you think this is a case of depression. This is a 30-year-old male with months of poor mood, weight gain, and he's now having hallucinations, really seeing things that are not there. This was not self-talking. This was actually seeing things around the room. Thyroid tests were normal. I'm sure you all knew to check thyroid and celiac. But there was one test and one treatment that brought him back to himself. And I'm wondering if anyone has any thoughts, especially from this side of the room. The other hint I will give you, the other hint that I will give you is that it was probably after some of the weight gain that he was having these troubles. He was someone that was trying out new sleeping positions too. He would sleep on his belly. Okay. So when we finally did a sleep study, obstructive sleep apnea, his was quite severe. They recommended CPAP. What I find with CPAP is that in patients that have very severe sleep apnea, if they are able to get it into their groove, if they're able to, and you really have to be persistent. Some people will try it first with no pressure whatsoever and have them slowly get used to the mask. If it really helps, boy, they love it. So it took time. It took working with a behavioral therapist who was able to wear a CPAP. They went on vacation. They drove like 5 hours away. They forgot to bring a CPAP, and he made them drive all the way back to get it because he did not want to go a night without it. I have a patient that wanted to wear it during the day just when he was awake because he just felt better. The hallucinations went away. The depression resolved, and even his weight got better as he was able to be more active. So sleep apnea is not in our guidelines that we have present now. It is coming in the future. By 2025, we'll have some new guidelines on that. But right now, the guidelines for children is everybody gets a sleep study by age 4. In adults, what I try to do is anyone who has hallucinations or weight gain or mood changes hasn't had a study of some kind, recently to go ahead and do that. How do you treat it? You can try everything from the tennis ball and positioning. Some of our patients do this themselves. They're very smart. They're crafty, find ways. Some of our patients will sit cross-legged and then fold it over. Guess you've seen that. So they're treating their own sleep apnea, which is pretty amazing, or sleeping face down. CPAP does work a lot better because it does actually push the excess tissue out of the way. BiPAP means that there's no pressure between breaths, and it's the patient's breath that triggers the pressure to start. And APAP is one that there's no pressure when they fall asleep, and then gradually over the night, more and more pressure builds up when they're already asleep. In terms of surgeries in children, just about the first line of treatment is taking out tonsils and adenoids. This doesn't seem to do so much for adults. They've tried lots of different surgeries. They've done the UP3, the uvulo-palatopharyngoplasty, where they take out the uvula in the back of the throat. These don't seem to work. Some people have a little bit of benefit for a couple months and then go right back to having apnea. The one that seems to have some promise is the hypoglossal nerve stimulator. I'm curious if anyone heard about this one, but I won't call on you, but yeah. So this is actually pretty well tested in adults. There are only specific types of airways where this is helpful. So my favorite otolaryngologist in Pittsburgh is Dr. Seuss, which is my favorite. I love being able to say, you're going to go see my friend Dr. Seuss. It's Soose, so it's not the same, but. So he will do an analysis to see, does someone have the type of airway where pushing the tongue forward will open it up? And if it does, this is great. It's a pacemaker placed under the skin. One lead goes to the lung, and every time that the patient takes a breath, there's another lead that goes to the hypoglossal nerve, to the tongue. And as you take the breath, it pushes the tongue forward while you're asleep. So there's no equipment necessary. But it is a surgery. It's a 140-minute surgery that's done to place a pacemaker. It's quite sophisticated, putting a line to the hypoglossal nerve, so it should be done by an expert if it's going to be done. So lots more coming on that in the future. Okay. Going over what do we know about aging in older adults with Down syndrome. So life expectancy is far greater than it has been before. Aging is atypical in many respects. And I've heard Dr. Chacoin talk often about 35. It's this time where often patients below the age of 35 look a lot younger than you might expect. And then there's something around that time, maybe around 35, where you might see more accelerated aging. I've seen a lot of cataracts in people in their 30s. Definitely arthritis starts at a much earlier age, especially in the cervical spine and the lower back. That being said, so many of my patients have such a high pain threshold, the x-ray looks horrendous, and they're fine because they can really handle it a lot better than the rest of us can. Hearing loss, again, very common. And then the one that I want to talk a little bit more about is Alzheimer's and when you start to look for that. This is a slide that I've worked on, got from Dr. Handon, who's one of our researchers in Pittsburgh. Talks about what is the cumulative incidence of Alzheimer's in Down syndrome. And my favorite take home about this slide is looking at how low it is at age 40. So if somebody comes in at 20, many patients come in at age 28, and someone said, we think they have dementia. And I say, I've really not seen dementia presenting that early. As Dr. Santoro mentioned, you start to see plaques and tangles building up, possibly, and on his slide, I think it was about age 15, when you started to see plaques and tangles start to build, but you don't see symptoms before about age 40. Then it tends to have a very big rise as you're seeing in the late 50s and into 60s, so much, much more common at that time. The average age of onset for Alzheimer's is, in some studies, 52. I've seen other studies of 56, but it tends to be about that range as the average. It tends to be a little bit more aggressive and faster than in those without Down syndrome. So 8 to 10 years from diagnosis, we're more like 5 to 7 in people with Down syndrome. What are the triggers of dementia? Yeah. Yeah, that's a great question. So the question is, in patients that have a family member that have a family predisposition to Alzheimer's, are they more likely to get Alzheimer's than someone without? And what we found is that the amyloid deposition from Down syndrome really trumps any type of family history. So it doesn't seem to have any noticeable effect. Definitely doesn't happen earlier than 40. So you really haven't noticed any difference in terms of if family members have that. I have found that some of our patients with Down syndrome are the most amazing in terms of their caregiving when they have family members with dementia. They really are patient and kind. Some of the best caregivers that I've seen. What are the triggers of dementia? We've talked about environmental stressors as a possibility. I've often seen when a patient lives with their parents can't take care of them anymore. So this is when their parents are maybe 80, my patient might be 50. They go from living with their parents to moving into a group home and really have trouble with that transition. And if there is a lot of stress that goes along with it, that might be a trigger. So life stage changes, transitions can be associated with that. I always try, if there's going to be transition, to start as early as possible in trying to make it a gradual transition as opposed to an abrupt one. What are the physical medical findings that we're looking for a diagnosis of Alzheimer's? And I think the one that comes across the most for us is this change in gait. Is maybe an early marker of someone that's going to have some cognitive decline. It's a very physical sign. I didn't put in a lot of slides about the plaques and tangles and amyloid. I think you probably have seen many of those before. But it's a very physical issue where you're having deposition of amyloid into the brain, along the blood vessels in the brain. So it's a very physical finding, and that's why gait seems to be one of these early markers. So any type of gait dyspraxia, so diminished capacity to correctly use the legs for ambulation. If I have a patient that I always take a walk with every one of my patients around the clinic. If they are shooting ahead of me, I'm like, that's fantastic. That gives me kind of very happy to see that. Much more worried when I see a new onset of difficulty initiating walking, harder to make turns, shuffling, fear of obstacles, those kinds of things. And what there are some other things to think about. So if someone has difficulty walking, and I watch them and they're never moving their neck, they're always going like this. Does anybody know what I'm thinking about then? Oh, it could be. Parkinson's is one to think about. Not so common in people with Down syndrome. It tends to be later on in life. But there's some people that just stop moving their neck. They're very protective of it. And this is that idea of atlantoaxial instability that we see more in kids. But if I have a patient that's just not moving their neck at all, I'm going to start looking at cervical myelopathy or some sort of a neck issue. The very severe arthritis can also cause problems there. So if their walking is a problem, start looking at vision, and then, of course, something within the neck itself. The other very physical findings, very concerned about new onset seizures. That's for me a big sign. New incontinence, and when I'm looking at incontinence, is often people that don't notice, don't seem to care as much about having incontinence, and then some sort of major behavior change where complete change in personality that occurs sometime around that in the mid-50s. So what is the evaluation? The one that I will do is the NTGEDSD, which is the National Task Force Group for the Early Detection and Screening for Dementia. I hope I got that right. And this is a 6-page form. First thing it does is it goes over the medical issues that can mimic dementia, and I'll go over those in a second, that are on the form. I think we might have to add some. And then it goes over these 6 domains. And I'm looking for someone that has a new change in activities of daily living, difficulty with communication, a major change in their ability for language, sleep-wake change patterns, that change in ambulation, which I mentioned before, and then changes in memory. And the last one is that behavior affect, a real big change in terms of big personality change. And you'll see these are different than the ones that you would see with regression. So these are, if I see changes in all 6 of these domains, there isn't much that causes all of these domains to change. If I see just one of the domain or 2 of the domains, that's when I'm really going to focus on what are the medical issues that mimic dementia. So let me go over those for you too. So these tend to be the most common ones. I think mental health is a big one. So we're looking for some reason for new depression, new anxiety, something that really triggers OCD. And these are patients that may not have a sleep-wake change, but will have a behavior change. Probably not as big a change in walking, but they might have a huge change in memory. So if I see these very large changes in couple domains and not in others. We talked about thyroid disease. Low B12 is what I test for in people with or without Down syndrome. Menopause, and I could give a whole talk about menopause. We don't know if treating menopause will have someone return to how they were before if you do estrogen replacement. There's no study of that, but will often is something that we will try if someone has new menopausal symptoms, which can be in those late 40s, is a very common time. Menopause is a little bit earlier in people with Down syndrome, probably about age 46. We talked about celiac and other GI issues. The one I wanted you to think about is constipation and urinary retention. I had a patient who came in with a decline in skills. And when I felt his belly, he was really protective of his lower abdomen. He had very severe urinary retention and just was so distracted by the fact that his belly hurt so much. He had a change in gait because it was hard to walk with a very distended bladder. Memory issues because he couldn't concentrate nearly as he had before. And then once we were able to drain out his bladder, get him on some medications to help with his prostate, he had a really nice improvement. Constipation can be the same thing, and this is one where many of our patients go to the bathroom by themselves, so you have to really chart it to see is there someone who's just not going as much as you would think that they should. If they are having some issues with distension, I'll often do at least some sort of an x-ray if it seems atypical, so if they're not having all 6 domains. And then hearing and vision, which both can occur about this time. Everyone should have an evaluation for cataracts because they're so common. And then you'll, of course, sleep apnea. If someone has never been tested for sleep apnea, new sleep-wake changes have to get a sleep study. What are the therapies, the non-pharmacologic therapies in people that do have dementia? I think, as Dr. McGuire mentioned, talking isn't always the best way to connect with people, but they have some amazing connections with music, other types of sensory input. I have a lot of families that put together picture books. If somebody has one of those PTSD-like events, showing them, a parent dying, bringing a picture book with pictures from the time when things were going really well, when they really see pictures of a lot of love, it can really bring them back to that time before whatever that event was, whatever happened. Picture books are really powerful. Having a small group of dedicated caregivers, our patients hate change, especially if they have Alzheimer's. So having predictability, consistency, and schedule are so important. And I've often seen patients with Alzheimer's really thrive in a great group home or a great center because they can have very, very clear schedules, predictability, don't mind eating the same thing for breakfast every day, and really appreciate knowing what's coming next. Very helpful. In terms of the medication therapies, and this is a pretty exciting future. I wanted to go over a little bit about this. My caveat for you is we have no long-term, we have no randomized controlled trials in adults with Down syndrome for any of our new medications. And I wanted to just walk you through a little bit. Let's see, am I still doing okay? Yeah, I'm still good. Okay. I wanted to walk you through a little bit of where we have been in terms of medications. So the first one was, and I'll go over donepezil, memantine, aducanumab, and lecanemab. So I'll start out with the brain chemistry drugs. So donazepam, glanamine, and rivastigmine, these are cholinesterase inhibitors. So they do nothing to plaques and tangles. What they do is they they kind of stimulate activity in the brain. So they might make symptoms better for a little bit in some people. In terms of the general population, it doesn't affect at all the actual natural history. All it does is kind of increase activity in the brain. In the studies of donepezil in people with Down syndrome, and they're very few, they didn't show significant benefit. Memantine, it does the same thing in terms of increasing the activity of the brain. So what it does is it blockades glutamate, which is supposed to be something that hinders cognition. There was one large study about memantine, which is Namenda. It was about 147 patients. The study was done by the drug company that makes the drug. Everybody involved in, just wait though. Everybody involved in the study was part of this drug company. They had 3 groups. They had a group with no dementia, and they had a group with dementia, and then they had a control group. And then they gave the drug to those with and without dementia. And in the findings of the study by all of these people, they had a lot at stake, said this medicine was not helpful. We don't need to do further studies on it. And I gotta say, that sounds pretty honest if they're willing to say that. I was very proud of that they weren't really trying to push the drug to say that, well, let's try a couple more studies, let's see what happens. But they didn't see the benefit in that pilot population, so they didn't want to press forward for it. So then this is the new class, and this is what you may have been hearing much more about in the news. So these are monoclonal antibodies. And the idea behind monoclonal antibodies is that they bind to the plaques and tangles. They bind to amyloid, and then they trigger the immune system to reabsorb that amyloid. So this is a drug that is actually affecting the natural course of the disease and the true structural issue of the brain. The first one was aducanumab, which is Aduhelm. There were very mixed benefits. Better in early stages. One of the studies didn't show any benefit. One said there was some suggestion. The problem was that there was significant brain swelling in 40% of patients that took it. And then we had the issue of brain bleeds. So if you have amyloid plaques that are on a blood vessel and you reabsorb that plaque, that's when you might see a brain bleed. Drug was $56,000 a year. It is given once every 4 weeks. So 12 doses, 56,000, that's pretty good. And we don't have any studies for adults with Down syndrome. So all of the major organizations said 2 things about this. The first one was we need to have people with Down syndrome in these studies because this is such an important issue. And the second one is we don't want to prescribe this drug until we see that it's safe. And we'll talk a little bit more about that. So the second one here is lecanemab, which is Leqembi. And this one seems to have a little bit more benefit in terms of there were better results of 27% had a decline so it slowed decline from dementia. It did not reverse anything, but it did slow the decline. The way they looked at this 27% was it was about 5 months in terms of slowing the decline. Still had the risk of brain bleeds and still had the risk of brain swelling less. So instead of 40%, it was 12.5%. So our question is, the risk may be higher in adults with Down syndrome because they have a high degree of the cerebral amyloid angiopathy. So more amyloid plaques, more of them are binding to blood vessels, so the risk of bleeding might be a lot higher. So there are now 8 other drugs like this that are all being tested. So this, I'm hoping, is going to be the future. I don't think these are the answer as of yet. Lumine is a fantastic organization that has been advocating for care for people with Down syndrome. And I put their name up here because they have a fantastic website which gives a lot more information about these medications and the real push for trials. So we're hoping to get people with Down syndrome into some of these studies to see if they are safe, to see if it does make a difference. I was talking with Dr. Santoro before this talk. Boy, it would be amazing to see how early do you start some of these medications. If you start when someone has a tremendous amount of plaques and tangles, you think that risk of bleeding might be higher. So what happens if you start at earlier ages? And I'm hoping that's where our trials are going to go. So my take-home point about dementia. It is the most significant issue facing adults over the age of 40. That being said, there are several conditions that mimic dementia that must be considered before you make the diagnosis. And treating options at this point are still limited. There's a lot to be said for a lot of these environmental changes. I have seen so many resilient, amazing patients with a fantastic quality of life with dementia. And it has to do with really finding the joy in life that many of our patients seem to be a lot better at doing that, at finding that joy in life, even when they have other limitations. So what do we have in terms of guidelines regarding dementia? So in 2020, we published our first study on the medical care guidelines for adults with Down syndrome. And the only one that had a lot of strong evidence for it was about dementia. And what we talked about was at age 40, starting to do screening. So in my clinic, I'll do that NTGEDSD 6-page survey and give it to a family member, give it to a caregiver to go over those 6 domains and to review the mimics to see if any of those are developing. And I'll do that usually every year, maybe every other year, but starting at age 40. So that the recommendation is starting at 40 to do some of these screens. And then the caveat to that is before age 40, before making a diagnosis of dementia, rule out absolutely everything else because it really isn't so common in younger people. So what about these guidelines? So this is started by I think I started trying to work on guidelines. I have an email from 2004 saying, hey, we really need to come up with some good guidelines for adults. And it took until about 2016, and we got support through Global to be able to hire ECRI, which is an organization that is an expert at creating guidelines. We have 11 experts about Down syndrome. We all got to talk through these issues. We formed 9 different committees, one for each medical issues, and we came up with these 9 as ones where we had 100 questions about all of these things. And we narrowed it down to about 22 questions about these 9 issues. So what ECRI did for us is they combed through the literature and they found 11,000 articles. So they went through those 11,000 to see which ones were helpful clinically, which were well done, which had a large enough population, and they found out of those 11,000, they found 22 studies. I'm so glad I didn't have to do that. That would to go through that. So they gave those 22 studies to this group of 9 experts. We also had I think we had about 25 other people that helped us to do this too. And we came upon what would be the recommendations based on these articles. What do we need to do for our patients? And seeing that we have patients from the ages here from, before 10 to up above 60. I'm going to try to cover about 4 decades right now. I think I can do it in about 15 minutes. Let's see if we can do it. So going through the guidelines. So what do we do if we have I usually start to see patients about age 21. So if you have a patient who's 21, a family member, what issues are unique to adults with Down syndrome? What do we need to address for everybody? So my questions out of this were, do I need to keep screening for the thyroid? The pediatric guidelines say we should screen for new thyroid problems every year, asymptomatic people, no matter what. Do we need to screen for diabetes? Is that more common in people with Down syndrome? Do we need to start screening for celiac? Does our patient who's 21 need a cardiologist? Should we be recommending exercise? Is that going to be the panacea of benefit in exercise? And do we need to screen for that atlantoaxial instability? So this is where the C1, C2, the 2 highest cervical vertebrae, they're unstable, there's too much space. Do we need to do x-rays for everybody? So those were the questions I think that come up when I see a brand new 21-year-old. I'll give you all the answers right now. Should we screen for thyroid? Yes, absolutely. And I'll go over some of the specifics about that for you. It's a little different than the pediatric guidelines. It may not have to be every year. But what we found in our studies is that new hypothyroidism can occur at any point in the lifespan. Diabetes, only if the body mass index, so someone that shows significantly being overweight, if it's above 30, then yes, you should screen for diabetes. Should we screen everybody for celiac disease? And I think that if you have a patient with no symptoms, there's no reason to put them on a gluten-free diet for the rest of their life, unless there's going to be some benefit. So only if there are some specific symptoms, a major decline in skills, a lot of GI symptoms. Otherwise, no reason to go looking for problems. Is a cardiologist needed? So if the patient has a history of congenital heart disease, then yes, it would be good to have a cardiologist involved. But as we found, the risk of coronary artery disease, if anything, is lower. So no reason to have a cardiologist unless you have underlying congenital heart disease. Exercise. Yes, exercise is very helpful. Is it a panacea? Maybe, maybe not. We'll talk more about that. And then screening for delayed-to-axial instability, same thing. Only if there are symptoms. If a patient never turns when they're turning their head, they go like this all the time. If they have a gait change, if they're complaining about weakness on one side or the other, then absolutely, I'm going to start doing imaging of the spine. Cervical spine is an area where we do see a lot of problems. So yes, but if there are no symptoms, don't go looking for them. Even if the person you care about is a roller coaster enthusiast, that's okay. Go ahead and let them makes them happy. So in terms of screening for hypothyroidism, the prevalence, very high, stays high, and it can present at any point. So 40% between the ages of 18 to 29, 50% in those over 30. So it does just keep going up as you age. So I check for this every 1 to 2 years. And treatment may improve cognitive function and weight management. So there are some benefits of treating it. So every 1 to 2 years, the test is a TSH. If somebody's having a lot of symptoms and I have a higher pre-test probability, I'll do a TSH and a T4. So I'll look at the actual hormone that's released, the active hormone as well as just the stimulating hormone if I'm really concerned. But if it's just screening, then a TSH is fine. How about obesity? Is there a healthy target BMI? Are there safe and effective treatments? And we did not find in the literature in 2020 safe and effective treatments that seem to change BMI. So exercise is great, but it didn't seem to help people with weight loss. I would love, if you could invite me back, to talk a little bit more about some of the weight loss medications, because this is a very new area. We've just started a new group as part of the Down Syndrome Medical Interest Group to look into weight loss medications. So something we might be thinking more about. I was going to say the day before I came here, I had to scrape all the ice off my car. Very happy to come here. So please invite me back. That'd be great. Okay. So for exercise, really nice meta-analysis about exercise. This is one of our wonderful patients who is a Zumba instructor herself. She's awesome. So what the study showed was exercise led to moderate to high effects on improving strength, endurance, and balance. Really didn't show much in terms of exercise about weight loss. What I would tell you, if you have a loved one who is a teenager, boy, I would get them into exercise. I would get them into having some sort of routine. Our patients are so much better if you get it into their groove than people without Down syndrome. So if you have it set that at 9 o'clock is treadmill time every day, can't move on with their day until that has happened. So if I had one word of advice for if you have someone who's under the age of 20, it would be to start thinking about diet and exercise and starting those healthy habits. So how about our 30-year-old? So let's say we have a 30-year-old who has, the mood seems to be changed from the last visit. They're less interested in friendships and activities. So am I thinking about dementia? No, thank you. I'm not thinking about dementia and someone who's in the 30s. Okay, so what am I thinking of? Am I screening for their thyroid at this point? Am I screening for diabetes? Am I screening for thyroid? Yes, awesome. So I'm screening for thyroid. Diabetes, absolutely. So now we start to screen for diabetes, anybody over the age of 30, between 21 and 30, just if they have that high BMI. And with this behavior change, so this is the part of the guidelines that Dr. McGuire was a big part of. Thank you for this, in terms of behavior. Two parts of that. The first part about behavior is first, look for a medical cause. And the second is, if you're looking for, in terms of a psychiatric diagnosis, which do occur, that get someone involved that has some experience in working with people with Down syndrome, because treatment is a little bit different than it is for those without. But with a new behavior change, first look medical, and then try to get someone involved that has some experience. Should we screen for high cholesterol in a 30-year-old? And should we screen for dementia? And I hope you're seeing there are a couple things I'm bringing up more than once, because these are the most important things that I have to talk about. So thyroid, yes. We're screening every 1 to 2 years till the patient is 99. Diabetes, every 1 to 3 years for everyone over the age of 30. The behavior change, we're screening for medical issues first, and then treating mental health issues and getting someone involved that has some experience. Screening for high cholesterol. So we don't need to routinely screen. I will screen people that have a family history. So this is one where, while with dementia, we don't see the family history having as much of a role. But cholesterol, sure, I tend to be a little bit more aggressive in screening, because that's what I would do in my patients without Down syndrome. But no reason to go looking for cholesterol problems in someone who's young. And then screening for dementia, no, not yet. So at age 30, you don't have to do that. So diabetes screening in asymptomatic adults.
Wake up. Sorry.
All right. That got everybody going. I like that. Kind of need that at 4:30. That's perfect. That was still got everybody's blood going. That's great. So with type 2 diabetes, we're screening every 1 to 3 years, starting at age 30, and again, keep going till age 99. For any adult with Down syndrome with comorbid obesity, we're starting earlier, so starting at age 21. So the risk for diabetes is something like 0.7% in those without Down syndrome, and then about 3 or 4 times higher, 2.5% and 3.5% in those with Down syndromes. Then it gets to be about 5% in those over the age of 30. So it's a little bit higher. In terms of cardiology, congenital heart disease, periodic cardiology evaluation to assess for risks of stroke, which is our big risk. Should we treat high cholesterol? And there's no data on should we put everybody on a statin or put people on aspirin, no evidence of any impact. So what I do in my patients is I do just what I would do for my patients that don't have Down syndrome. And I screen everybody at age 40. I do a 10-year risk calculator to see if I should treat for cholesterol or not. In patients that have diabetes, much more likely to treat cholesterol. In patients that have a history of if they've had maybe a history of any type of stroke, sure, I might be more aggressive. Otherwise, there isn't a lot of data about that. Okay, how about our 40-year-old? So our 40-year-old has some new gastrointestinal issues. So what am I screening for at this point? Right, so should I screen for high cholesterol? Yeah, sure. So at age 40, that's when I would screen for high cholesterol in my patients without Down syndrome. So go ahead and start. Screening for dementia. Yes, and so this is when we start screening for dementia, and we'll do some sort of any type of evaluation. I love to find anything that covers those 6 domains. And then how about celiac testing? Is that too late? Could you develop celiac at this late in age? The answer is yes. So I would do a screen for a celiac in someone who has new GI issues. And again, I have that low threshold for doing swallowing studies for upper symptoms. Okay. And then we have our 50-year-old. So what issues are we covering for now? And let's say that our patient who's 50 has a new vertebral fracture, so fracture in their spine. So one of those 9 groups that we were talking about is what we found is that our patients do have a higher risk of osteoporosis, higher risk of low bone density. What we don't know is if we should be treating this or not. Does it make a difference? Are we preventing fractures? But we did find that if you do see fractures, then you really have to be aggressive in treating for low bone density. So we're looking for those. In the guidelines, we talk about doing screens for secondary causes of low bone density. So in a patient with with a vertebral fracture in their spine, with a hip fracture. I'm looking for low vitamin D. I want to know if they've been on steroids for a long time. Have they been on anticonvulsant therapy? What are the kinds of things that might cause low bone density? And we're still screening for dementia. Keep doing that. Yeah, you have a question. So the question is the osteoporosis related to genetics? So absolutely, it must. So everyone with Down syndrome has that same 16,000 base pair region that has all of these medical effects, some behaviors that are common. There is something about that 16,000 base pair region which changes the composition of bone. What we still don't know is, do we treat it the same way that we treat everyone else? Do we use bisphosphonates? Do we use alendronate or medicines like Fosamax is one of the brand names for those? We don't know how beneficial they are. If I see a low bone density, signs of fractures, I'm going to have my endocrinologist involved. And in most of the times I have an endocrinologist, they will try some of the first line things like a bisphosphonate, which we do for other people. But at the same time, they're much more likely to try some of the ones that really help to build bone, because they're probably more effective in people with Down syndrome, because there is a true genetic difference in how they get osteoporosis. Yeah.
What if there's genetics in the family? So mother, aunt, sister, all have severe at age 45.
Yeah, so if it's that young, so the question is, in somebody with a family history of osteoporosis and very young, so at the age of 45. So women without Down syndrome, we start looking for osteoporosis several years after menopause. So if you're seeing it as early as 45, there's probably a genetic some sort of a genetic marker. We probably won't see what the marker is because we don't have those yet. But yes, I would probably be more aggressive. So I would start at age 40 doing a screen for low bone density. all you have to do, yeah, is bring those guidelines in with you. We now have a hard copy, and I'll talk more about that too. Bring it with you to clinic. So could you have your doctor talk with us? Absolutely. So this is where getting a case before an echo group would be a wonderful way to educate your primary care physician. We found most primary care physicians really enjoy taking care of people with Down syndrome, but do feel at a disadvantage. Would love to know more about it. And so we found them pretty excited to be able to present to a field of experts. So hopefully we'll do that more. So my question is, how do you remember everything I just put in there, right? So luckily, there is a handy one-page handout, okay? You don't have to memorize this one. As part of the Global Medical Care Guidelines, if you go to the Global Down Syndrome Foundation website, this is free to all. This is what you should bring with you to your primary care physician. And I heard someone say they picked out their primary care doctor as someone who was willing to listen to a family member and say, hey, this is a guideline that's come out for adults with Down syndrome. I'm not sure if you'd be interested in learning more about it. Bring this with you. And if your doctor is willing to be flexible and be involved, that's a great doctor. As I found with my nutritionist in our clinic and with our psychologist, you can become an expert pretty quickly if you just see a couple people with Down syndrome and put some time into the literature. So your primary care physician can become an expert, can become an advocate with you. So in terms of the other, you'll notice that in the guidelines, I didn't talk about sleep apnea. I didn't talk about cancer screening. I didn't talk about ophthalmology guidelines. And those are going to be coming out in 2025. So that's our next round of guidelines, where we picked a whole nother slew of topics to go over. So my take-home points for you. We have new guidelines. Everyone should be screened for thyroid. Diabetes screening, everybody over the age of 30. And this is now, should be standard of care for adults with Down syndrome. Dementia and respiratory issues still most important in adults care. So things to start watching for. But again, start at age 40 and not before. Just want to say thank you. I think I got through everything in time, so we can bring up all of our experts. So we have time for questions. I am so excited to have Dr. Santoro and Dr. McGuire. I feel like, Jessamy, I think you did a fantastic job of having three topics pretty nicely covered by, you got some pretty amazing science through Dr. Santoro. The psychology from Dr. McGuire, and mine is more the medical side. I think this really covered a lot of nice issues for you. So let me bring everybody up, and then you can ask questions of all three of us.